that was the huge aha moment, was we need to be partners and co-create everything that we build with the goal that the units want it, the teams want it, the leaders want it. Clinical teams, clinical departments, clinical units, clinical leaders, they need to be the psychological owners of these programs.
Partners first, designers second.
The shift, I think, in these partnership conversations is that we start to see how much people and teams don't feel ready for the things they see frequently, that they see every single day.
Welcome to the Center for Medical Simulation Grand Rounds. I'm excited today because we're going to be talking about a paper that's just come out in Advances in Simulation. It's called Readiness Planning: How to Go Beyond Buy-in to Achieve Curricular Success and Frontline Performance. This is Jenny Rudolph. I'm the Director of Innovation at the Center for Medical Simulation in Boston. I also happen to be the senior author on this paper, but today I'm going to be the facilitator of the conversation. We're going to dive into our introductions of who's on the call shortly, but what I'd like to start with first is kind of the origin story of readiness plans. Chris Rusin, I know this came about because of some struggles and successes that I think you had in your past. Can you get us started? How did this all come about?
Yeah. Wow. Thanks for asking, Jenny. And good to be here with everybody. Yeah, readiness plans, the origin story of readiness plans goes back to my time at Boston Children's Hospital. And I really didn't know a lot about hospitals, strangely, but I knew a lot about human behavior, a lot about training, a lot about teams. And I entered the hospital with the job of director of simulation education, essentially at Boston Children's. And my mandate was to bring simulation to the whole hospital. It was kind of a simple mandate. And as I started to learn about healthcare, learn about how hospitals worked, and learn about simulation within hospitals, I learned that there's all kinds of opportunity in simulation, but also every simulation program was different, and some were more wanted than others. And what I learned about some simulation programs is that sometimes it felt like the simulation program was being forced on the population for one reason or another. It was someone's project or someone's wish that simulation existed. And that was one rough category of simulation. And then another category of simulation was simulation programs that were needed because people had to learn something in order to be ready for some kind of patient or ready for some kind of moment. And as I had my notepad out and I was noticing the differences in simulations and different training moments, that was really the birthplace of readiness plans, as I noticed that those simulation programs that were directed towards readiness of people for things were the ones that were desired in the moment, sustainable over time. If you canceled them, people said, "Why did we cancel that? Can we reschedule it? We need to have it." Because those were the programs that were getting the hospital ready for all of the different types of patients that were coming in. And at Boston Children's, wow, there were lots of different complex types of patients coming in across that enterprise. So that was really the birth, noticing that difference, Jenny.
Wow, Chris, thanks. And I think we are all aware of the huge gap between how simulation programs are often perceived, which is we're kind of at the risk of seeming sort of irrelevant, compared to how very wanted we were to help people get ready at the beginning of the COVID-19 pandemic. For example, in the hospital I was part of at the time, pop-up simulations in the OR to learn how to manage a COVID positive patient being intubated. The simulation folks were everybody's best friend and very, very wanted. So the mission of readiness plans, I think, is to get us to the place where we're really wanted and really appreciated. So let's talk a little bit about who's here. So if I could ask you to introduce yourself, what do you do for work? And Grace Ng, may I start with you?
Thank you, Jenny. I am Grace Ng. I am the Senior Director overseeing faculty development programs at the Center for Medical Simulation.
Mary Fay, tell us about yourself.
Mary Fay. I'm a nurse by profession, and I am the assistant director working with Chris in the Division of Applied Learning for Performance and Safety.
James, tell us about yourself.
Hi, my name is James Lipshaw. I am the Assistant Director for Instructional Design and Media at the Center for Medical Simulation.
Enrique.
Hello, everyone. My name is Henrique. I'm from Brazil. I am the coordinator of the Simulation Center at IMEPAC and the Chief Learning Officer at HUSF, which is the Hospital Universitário Sagrada Família.
Chris Rusin, tell us about yourself.
Thanks. I'm Chris Rusin. I'm a senior director and leader of the ALPS team, Applied Learning for Performance and Safety, at the Center for Medical Simulation.
Okay, team, thank you so much for introducing yourselves. What I'd like to do now is link into what I think is the profound mental shift that we make with readiness plans. And it has to do with partnering and it has to do with design. Chris, could you talk to us about that?
Yeah, sure. So I think the big shift is really the so what out of that origin story of readiness plans, which is that sims that are relevant to readiness are the ones that succeed. And then what flows out of that is the idea that simulation organizations or teams or training teams, whatever that organization is within the health system, needs to know what is needed, what is desired around readiness, and needs to partner with the clinical teams and units and departments and leadership in order to design and develop and deliver, produce, be part of simulation-based training programs that are great, that are effective, that are powerful, that have a positive impact, that are sustainable over time. So really an implication for simulation people of various types is that we need to be partners with the customers of the training. We need to be partners with the people who are being trained, and they need to be the owners psychologically of that training. They need to feel that it's their training. And the only way to get to that place with it is for them to actually be the designers of it or the co-designers, co-creators, co-developers of it. And that's really, you know, back when I was faced with the big challenge of how to make simulation successful across Boston Children's Hospital with our team there, that was the huge aha moment, was we need to be partners and co-create everything that we build with the goal that the units want it, the teams want it, the leaders want it. Clinical teams, clinical departments, clinical units, clinical leaders, they need to be the psychological owners of these programs.
So Chris, we have a phrase in the paper that I think speaks to this powerfully, which is partners first, designers second.
Yeah.
And I know for me, that's quite different than what I've done in the past.
Jenny, you know, as an instructional designer, 10 years ago, it felt like when folks talked about clinical simulation in particular, a lot of the time what you heard was we work on low frequency, high acuity events in simulation. This is a batting cage for things you don't see very often, so that when you do see them, you've practiced them before. And the shift, I think, in these partnership conversations is that we start to see how much people and teams don't feel ready for the things they see frequently that they see every single day. When you are practicing low frequency events, even if they're high acuity events, that doesn't feel important or relevant to teams that aren't even ready for the normal speed pitches that they're getting. They're not ready to talk about hitting a knuckleball. Like, we need to be able to hit a fastball. The thing that we see 90% of the time, we need to be able to do that because we don't feel ready for it. So I think that's a big shift in talking about partnering first. We're not making these tricky, difficult, obscure sims. We're making things to get teams ready to do the things that they see every single day.
On the theme of thinking about situational competency, I'd like to pivot now and talk a little bit about what is a readiness plan. To make an analogy to things that I think a lot of us in the simulation community are aware of, when we use something like rapid cycle deliberate practice to get resuscitation teams ready in the work that Betsy Hunt has described so beautifully, if you want a team to be ready to manage asystole, if you want a team to be ready to manage VFib, Maybe you want them ready to manage that in the ICU. Maybe it's on the floor. Maybe it's an unexpected situation somewhere else in the hospital. Those are each unique situations that have people and stuff around them, not just the skills. And so, Grace, I was wondering if you could kind of help us think about that from your area of obstetrics and midwifery. I know this idea of focusing on situational competency has been kind of a game changer for me, but I don't actually practice clinically. So I'm wondering how you see this from your field.
Thanks for asking. And I think that for many obstetrical practitioners, and for me, I am an OB nurse and a midwife by training, and I know many obstetric practitioners love a good delivery. However, when it comes to precipitous deliveries outside of the labor and delivery unit, it does make people feel extremely nervous when people have to think about, oh my gosh, when things are happening so quickly at a drop of a hat, am I and are the team able to manage that when situations arise so quickly in an unfamiliar environment? And I think readiness plans, having a readiness plan to manage precipitous deliveries outside of a typical setting of a labor and delivery unit really helps the team be prepared at the drop of a hat.
Grace, let me jump in. Like where?
Yeah, for example, in the parking lot of the hospital or in the lobby of the hospital. And these situations are becoming more and more common because so many patients in rural and semi-rural areas need to travel long distances in order to get to the hospital. And sometimes they are just so close, but they don't quite make it into the safety of the labor and delivery unit. And very frequently, the team need to go meet them where they are, where the baby is being delivered. So the team needs to be ready to respond in a very quick manner and come together very rapidly.
So Grace, let me just say this back to you. So the situational competency is, I not only have to manage a delivery with my team, which itself has its own challenges, but we might be at the front door of the hospital on a cement sidewalk without all our standard equipment, with other people walking by. That's the situation or a situation. Am I missing anything there?
Yeah, no, very well said, Jenny. And that's a reality of the situation. And I think thinking about that context and thinking about, I guess an adage comes to mind, the whole is greater than the sum of its parts. So I feel like, you know, if we focus on training individual clinicians on the individual skills of being able to deliver a baby, people can do that. However, having a readiness plan for the team to be ready to manage a delivery outside of the unit, like you said, on the cement sidewalk, maybe in the cold, where your normal equipment are not available, really helps the team to shift their focus on thinking about, do we have the right mindset? Are we thinking about the totality of the clinical complexity? For example, is the baby full term? Is it preterm? And also thinking about the capacity of the team. How many people do we have and what is the combined skill set? Do we have the right people?
So Grace, great. So we have this complex situation where people are having to have a lot of interpersonal cognition, manage the clinical steps of a delivery. So that's sort of our setting that we want to get people ready for. So what I'd like to just ask you or others, feel free to chime in now, is part of what we think about in readiness plans is once we have a sense of that situation, which we arrive at in dialogue with our partners, we then have to create some foundational skills or ensure that people have foundational skills to get to that situation. And in my opinion, that's sort of the game-changing aspect here, which is instead of starting with the foundational skills, we start with the situation and then work backwards in a design thinking sort of way to figure out what are those foundational skills. Some thoughts on that?
You know, Jen, some of the roots of that and my thinking about readiness planning were in being a fan of NFL football. And, you know, it's not a totally global sport, but it's a very easy sport to break down into situations because in NFL football, a play begins, they have the play, which is a situation, we call it a play, and then the play stops, they reset, and they start another play, which is a situation. And so when you interview NFL coaches and coaching staffs, because they have really teams of coaches in the National Football League, you hear them say, we need to be better with situational football. We practice these situations, we practice those situations, but we hadn't worked on these other situations as much. That's why we lost the game, or that's why we won the game. And I always found that fascinating when I was listening to those coaches. Now, if you take it into healthcare and you think about a shift in the hospital, whether it's in labor and delivery or really any of the units in the hospital, you can actually, using that thinking, you can say, well, what are the different situations that exist throughout the day? And actually, if you add up all those different types of situations, that is the shift. That is the work. So
And so we're sort of
yeah,
thinking about competence instead of sort of this global thing that's owned by a person. If we use the analogy of plays in a football game, there's situation A, situation B, and throughout my day, I have to be ready for different situations.
Jenny, just to sum it up, you know, in some simple language, a readiness plan is writing down a situation or multiple situations that you want people or teams to be ready for. And you write those down, you record those. Could be as simple as on a piece of paper or in a document of some sort. And then you extract from those situations all of the individual skills that are needed to manage those situations and navigate those situations, and you write those down too. And what you end up with is a couple columns of lists of skills. We'll call that column 1. Those are all the micro skills, individual skills, distinct skills that people need in order to recognize that that situation is happening and manage that situation. And then in column 2, let's call it, you have the list of situations that is the focus of the moment, or the focus of the readiness plan. I like to call those the get ready columns of the readiness plan. And like you said, we start with situations, and then we think about individual skills within those. And then there's one more column in the readiness plan, which is the stay ready and improve our readiness column. And that's a little bit different. That's actually a list of things that we do within our teams in order to maintain our readiness and improve our readiness over time. So now we've got 3 columns on a readiness plan. We've got the middle column, which, like you said, is the central column of focus, which is, these are the situations that this readiness plan is about. All right. And these are the ones we need to be ready for as it relates to this readiness plan. And then in column 1 are all the individual skills inside of those situations that people need to navigate those. And then in column 3, what are things that we can do to maintain and improve our readiness? And in sum total, that's our readiness plan.
Awesome. And I think one of the painful things sometimes for us educators is we have this grand idea of the foundational skills that our learners shall be ready for. And in fact, when we start with the situations, we end up having to prune a lot of our favorite things because they might not be that relevant. And I think that is both a little bit difficult, but highly enabling. One of the things that interested me so much about readiness plans is the struggle I've faced from time to time, and I have talked to many simulationists about this, about feeling kind of irrelevant. Like we're sort of on the side, our sim center's over there. People maybe come, maybe they don't really see the point. And I think one of the big shifts has to do with something called psychological ownership, like who actually owns deciding on those situations. And I want to explore that a little bit. And what does shifting psychological ownership even mean? Mary, in the paper, you outlined a readiness plan for new nurses being able to manage the first 5 minutes of a deteriorating patient. And, you know, on the face of it, many healthcare systems have that problem. It certainly makes a lot of sense, but actually getting a nursing school to get people ready for that, getting people who run a nurse orientation program to get the nurses to it, sometimes not as smooth, even though people feel like it's important. So I wonder if you could talk to us a little bit about what happens or how it happens that people actually own the problem as the groundwork for a readiness plan.
You know, it couldn't be more timely because of what's going on in nursing education in the United States. The American Association of Colleges of Nursing released their new standards recently, and data showing the declining readiness for practice of new graduate nurses. Not entirely in response to that, but in a move to competency-based education. And so what competency-based education really is asking nursing schools to do now is to take ownership of the concept of new graduate readiness, because I think for many years, nursing schools had the idea that their job was finished when the new nurses passed their licensing exam. And that was the measure. Well, they passed their NCLEX exam. And now the American Association of Colleges of Nursing and all of the clinical partners who both support clinical rotations and hire the graduates are saying, we need something very different than what you've been doing for the past 20 years. And so you're really seeing nursing schools now take psychological ownership of this problem of readiness. And I was really smiling to myself, Jenny, when you said, when you start thinking about the situations and then backwards design your curriculum, you prune away a lot. And there are many sacred cows dying in nursing schools across the United States these days because the pruning is happening. Because people are getting very serious about thinking about what are the situations a new graduate nurse has to be ready for, and then reverse engineering the curriculum to meet that. And so it's a really interesting shift, and we're seeing it happen right before our eyes. And I was telling Chris, I was just at the national conference of AACN these past 2 days, and sim zones and the idea of readiness planning are being embraced in a big way in nursing these days because it's just such a logical way to think about it.
So Mary, let me get really concrete about what exactly is psychological ownership. And then I want to talk about an example. So first, when I was reading up on psychological ownership, I came across a definition, something like psychological ownership speaks to what I consider to be mine. And things that are mine, I care about how they're done. And I even might get my nose out of joint if somebody steps on my turf and doesn't do it right. So that's kind of what we mean by psychological ownership. And one of the things you've spoken to me about, along with Kate Morse and Grace, I know you've been doing some work on this just recently in South Carolina, is this idea that clinical partners like hospitals or clinics have some ideas about what they need nurses to be ready for, and they are not standing for it anymore, as you noted, if the nurses aren't ready.
With the shift to competency-based education, AACN is recommending very strongly that when schools begin their curriculum revisions, that their clinical partners are at the table. So I think it's coming from the clinical partners, it's coming from AACN, and the new accreditation standards are going to be looking at this kind of a thing. And so, nursing schools have always wanted to do a good job. I don't mean that they haven't. But I think that the accelerating pace of change in the healthcare system has, it's just been incredible in the last 4 years, but really over the past few decades, and nursing education hasn't changed at all. And that's why we've seen this widening gap, academic to practice gap, as we call it. And nursing schools aren't satisfied with that. They know they're not meeting their clinical partners' needs, and they want to. And they also want nurses who will graduate and stay engaged and can thrive in the workforce. And when new nurses enter not ready, they don't last as long. And schools of nursing don't want that to happen. They want to graduate people who can thrive and contribute in the healthcare system for a long time.
So what I'm hearing you say, Mary, is previously the curriculum at a nursing institution might have been designed around getting that licensure examination passed. And now the first step is partnering with the healthcare organizations in the community that need these nurses and saying, what do people need to be able to do on day one as a worker in your institution, as a member of your teams? And then working backwards and saying, oh, all of these things that we were teaching in the past, all these educational moments, these designs that we had, those actually weren't what's most important to our partners.
Exactly. Yeah, that is exactly it in a nutshell, James.
Yeah.
Folks, I want to talk about readiness plans as boundary objects. It's kind of a funky term from sociology. And Chris, I'm going to turn to you as the fellow org behavior person on the call to give us a quick definition.
Thanks. I love sociology. Well, I think of a boundary object as a bridge essentially between two teams or two cultures and or an interface or a translation, magical translation device. In our case, we're thinking about a boundary object as a document that translates concepts for two sides of a program. And those two sides are the sim team or the sim learning team or the training team, and the other side, and we're thinking of this side as the very important side because they're the ones who need to be trained, they're the clinical team. The clinical team,
Awesome.
language and concepts that they use every day that are the ones that they understand. And the training team has concepts that they use every day that are the ones that they understand. We need this boundary object to translate for both teams. At least that's the way that I view it, Jenny.
Excellent. So let's think about how this might have played out, for example, in a hospital. And in Hiki, I know you've been using readiness plans to help your faculty get ready to do certain things. And I wonder if you could talk to us a little bit about your journey.
Okay, I'll talk about two aspects. One is about faculty development in the med school. So before the readiness plan and the new program, we felt many people like frustrated, faculty frustrated, students frustrated because of the activities weren't very pleasant and well done. And sometimes the frustration of the faculty was, I had a Zone 2 simulation, and the situation, it was very well designed, but the students didn't have the skills necessary to be inside the simulation. So it was very frustrating for the students because it was like a trap. So they didn't get me these skills, and now they are applying a situation and I have to show these skills and I don't have it. So the idea to create this new faculty development using sim zones and readiness plan was to bridge this gap. And we started 4 years ago, and the program has been very successful. And now we have many other challenges like turnover of faculty. The time available for training for faculty is low than previously. So now we are redesigning our faculty development with the help of Mary and Lon. So in the hostel, shifting to the hostel, what I notice is when we use readiness plan, sometimes we think about, oh, this is the nurse knows, or the nurse technician knows these skills. And sometimes not necessarily they don't know, because sometimes it's a different situation or a different hospital or a different equipment. So the idea of having a readiness plan in this context has helped us to think about not only individual skills, but also for teamwork skills, because sometimes we think about technical aspects of one profession or every single member of the team, but we need to interact. We need to use different resources to set the team. So this has been very impressive for me, and it's helping a lot to have better training in our institution.
That's great, Enrique. And what I'm hearing, aside from the skill readiness, is the impact on relationships. Because I can imagine if the medical school faculty create a simulation where the learners, the medical students, feel trapped, that is sure not going to be good for their relationship. And if in the hospital, a training is created that's supposed to focus on some sort of technical skill, but people don't even know how to communicate with each other, again, they're going to feel resentful or frustrated. So the side effect that I think you're addressing not only is skill readiness, but relational coordination and readiness.
Yeah, and in this regards, people feel that the training is meaningful, and they want to be part of the training because they know it will help not only for himself or herself, but also for the teamwork.
All right, so we're coming to the end of our time. And Chris, I'm going to come to you for the last word in a moment. We've all been kind of in the trenches, I think, for many years, seeking to find ways to make the experiential learning we know how to create actually make a difference. And I think finding a way to do that is something precious and powerful for many of us. And I wonder if you'd care to share some final thoughts around that journey for yourself, Chris.
Yeah, wow. Well, thanks for giving me this opportunity. Everybody here gathered has amazing stories, to answer that question. And I think that we have in simulation, we have incredible equipment. Like you said, we have these great curricular models. We have amazing, smart people, teams of people, very nice simulation rooms and centers often, sometimes more modest, but we also have a lot of frustration often. It feels like our programs are hard to schedule, hard to develop, hard to deliver. They happen in people's free time when people aren't being paid, very early in the morning, very late at night, at inconvenient times. And to me, those are all signs of programs that were not developed through a partnership and were not co-created. And, I learned all these lessons the hard way, to be very clear. I developed lots of programs of that type and had to learn from that. What we have learned over time is that when you build a readiness plan with a group of people and they tell you ultimately what their people need to be ready for and ready with for skills, now you have incredible shared motivation to build a great simulation-based training course that gets people ready. And we use the language of sim zones, gets people ready with individual skills in zone 1, gets people ready for situations in zone 2. But you're motivated on both sides of that partnership. And the readiness plan is a symbol. It's a very powerful one. And it's also incredibly clear. This is what we are getting people ready for. If we build our simulation programs out of something so clear and so motivating, we're going to have a lot more consistent success. And and that success includes getting programs funded, because it's very natural to fund a program that gets a team ready to do what they do every day, to James's point earlier. And so that is the logic of partnership that this paper talks about and that we're talking about today. That's the logic of partnership and really relevant simulation training development that we do with our partners every day around the world, including Enrique and his amazing team. And we're very excited to talk to people more about this and learn more as others are trying to do it and really develop a community around this type of development.
Thanks, Chris. Thanks, Grace, Mary, James, and Enrique. If you'd like to know more about readiness planning, head over to the Advances in Simulation website and check out the paper or their social media, or come on over to our website at the Center for Medical Simulation, harvardmedsim.org, and you can learn a little bit more about it there.